So the next one up, why do we need oxygen? Well, after seeing that, I guess we know. So Dr. Leigh Minuk is our next speaker. And Dr. Minuk is a respirologist and clinical instructor at VGH. She is a recent graduate of the University of Toronto respirology and interstitial lung disease training programs and completed a clinical epidemiology diploma at McMaster University. Say that quickly. She has a special interest in cystic lung disease and sarcoidosis? Sarcoidosis, okay. She is involved with the administration of clinical trials and is focused on quality improvement and resident education. So welcome, Dr. Minuk.
Hi, everyone. It's so good to be here again. I recognize a lot of faces from the crowd, so thanks for coming out today. Today I'm talking about oxygen in interstitial lung disease. So just to kind of get started, I don't have any disclosures that are relevant to this talk, and I'm not going to be making any medication recommendations. But what I do want to talk about today, we'll spend a bit of time understanding how oxygen is taken up in the lungs and how that's impaired by interstitial lung disease, so we'll go into that a little bit. We'll recognize the effects that low oxygen actually has on your body, so how that affects your overall feeling or lack of a sense of well-being, how applying oxygen can be beneficial, and some risks that may be associated with oxygen use, because like any medication, there are drawbacks. And then we'll talk a bit about ways oxygen can be delivered and transported and how we actually get oxygen applied for, how we get it funded, and what to do when you don't have funding for oxygen. And then we'll talk a little bit about frequently asked questions that I get asked. So first step, let's go through like this med school crash course. And there's no test at the end, no quiz, so I'm just hoping that some of this really feels relevant. So the first question is, how does oxygen actually get into the blood? And Dr. Gooby kind of introduced this sort of idea, but when we think about everything that we breathe in, some of it is that really terrible PM 2.5 stuff, even if we try to avoid it. But there's 21% oxygen in air. The rest of it, or the majority of it's made up by nitrogen. But for the purposes of simplicity, we usually say you're breathing in oxygen, and then you breathe out carbon dioxide. What happens in between is some big black box, right? Well, we're going to talk about that. So if you go really deep into the lungs, so oxygen goes through the airways, through the large airways, into the small airways, and kind of like a tree that prunes out at the end, those airways just get smaller and smaller and smaller until you get to these tiny little air sacs called alveoli. One of them is called an alveolus. And the walls of the alveoli are so thin. Think of it as like a sheer material or a mesh where certain things can get in or out if they're small enough. Things that are small enough, things like gas, things like oxygen, carbon dioxide, can get in past the walls of that alveolus. And actually through some of those blood vessels that are so small also have a mesh-like kind of wall to them where gas can get in and gas can get out, and it actually moves through in and out quite easily. And so you breathe in oxygen and carbon dioxide kind of shoots off of the blood vessel or off of the blood cell. Oxygen gets in, it attaches to the red blood cell, and then it goes all the way around to the rest of the body. And the heart does a big job. I mean, I think the lungs are the most important, but the heart's important too. And the heart pumps all of that blood around, basically to the periphery, to your hands, your arms, your legs, and it allows you to do exercise and work. So what happens, though, when we introduce interstitial lung disease or pulmonary fibrosis into the mix? So you may wonder, okay, I get asked all the time, what's the difference between interstitial lung disease or pulmonary fibrosis? And I often tell people, well, interstitial lung disease is this umbrella term, so it sort of encompasses anything that happens in this imaginary space called the interstitium. Well, this is the interstitium. It's this space between the alveolus and the blood vessel. And that area can get scarred down, it can get filled with inflammation, When we're talking about scarring, that's when we're talking about pulmonary fibrosis. When we're talking about inflammation, that may be fluid and a whole bunch of other stuff. But really, that pulmonary fibrosis impedes the ability of oxygen to get in and doesn't so much impede carbon dioxide to get out. It's pretty good at leaving, but oxygen really has trouble getting in. When you have mild disease, this may not actually affect you because oxygen's still pretty good at getting in. But what happens is when you exercise, your body, your muscles really need more oxygen. And they say that, they sort of shoot that message up to the heart catches on, the heart starts pumping faster. So what's happening is now all these blood cells are moving through that tiny little blood vessel, and they're moving so fast. And if you think of it like these are little sort of trains moving along through a train station, you've now shut a bunch of doors. You've shut a bunch of doors so those oxygen particles can't get through, and now the trains are moving faster on top of it. Maybe with the train slow and stopping, they could get on, but now they can't. And so we see the oxygen drops really quickly when you start to exercise, and that's even in mild disease. When you start taking severe disease, when there's more fibrosis in that interstitial space, then you have a problem even at rest. So even then, you can't seem to get as much oxygen in because you have so few doors for those oxygen molecules to get across to those blood cells. And so what happens then? What happens to the body if the oxygen levels are low? It may be completely asymptomatic. You may feel fine. It's kind of like breathlessness is very complicated. It's like pain. You know, you hear some people say, I have a really high pain tolerance, that's not going to bother me. Breathlessness is very similar. So you may have a very high level of perception of breathlessness. You may feel breathless at the slightest movement, but your oxygen levels actually aren't that low. It's complicated, and it will also change depending on how severe your fibrosis is and how that's affecting your ability, your lungs' ability to expand, that sort of feeling of pressure, like a squeeze on your chest. Muscle dysfunction can also be a consequence of low oxygen levels. If you think about it, your muscles are the ones that are saying to your heart, you know, you got to pump faster. And so if your muscles aren't getting the right oxygen, they're not really going to be operating at full capacity. You may have some impaired cognitive function. You may not be thinking right. You may kind of feel a little bit sleepy, like you couldn't really answer, you know, a quick question. And pulmonary hypertension, and you hear us talk a lot about pulmonary hypertension, either in the lung clinic or here you've heard it mentioned a few times. It's really high blood pressure from the blood vessels that lead from the heart to the lungs. And because all of those blood vessels are sort of nestled around those air sacs, you can imagine that with fibrosis, those get affected too, those get distorted, those get pulled on, and they change shape too. And you end up having higher blood pressure in the lungs, and that's actually associated with an increased risk of death. And so we get really, really concerned when we see pulmonary hypertension, and one of the ways that is hypothesized to at least prevent that is to make sure that your oxygen levels are not chronically low. So the obvious solution seems to be just give more oxygen. So we supply oxygen usually at a given flow rate, usually in liters per minute. So when you hear your doctor ask you, what's your oxygen rate at, it's just a flow rate. It's not a percentage because everything that comes out of that canister should be 100%, but it mixes with air, so it's not quite 100%. It's based how quickly that flow rate comes out. So then we give more oxygen, and you just increase your chances that that gas can get through the door and onto the blood cells. So in terms of supplemental oxygen use in lung disease, we think it can relieve shortness of breath, and certainly it can. A lot of you, I see some folks on oxygen around, you probably notice you can do more and you feel a little bit better with oxygen. This has been studied before, at least in sort of heavy exercise, and sometimes the results may be mixed in terms of what that has shown in terms of improving breathlessness in heavy exercise, but certainly if your oxygen's low at rest, it can relieve shortness of breath. It can prevent deconditioning, so it can allow you to do more. It can allow those muscles to continue to work to their full potential. It can improve your quality of life, so you can, again, do more things that you used to do or want to do. And then preventing pulmonary hypertension. And the sort of idea here is that If you prevent pulmonary hypertension, and pulmonary hypertension is associated with an increased risk of death, well, then you're living longer also, which is pretty good. But of course, like any medication, oxygen has drawbacks, and I'm painting a very rosy picture of how good oxygen is, but there are reasons you may not want to use it. One of the most common reasons I hear from my patients is that, well, I don't want to look sick. I don't want to look like I'm carrying something around. I don't want people to know I have a disease. I don't want my family to be more concerned about me. And I think that's really fair because it is very visible. We don't have a good sort of way to completely hide oxygen because you do require wearing tubes in the nose during the day. The other thing that I hear a lot from folks, and this is part of troubleshooting of oxygen, is the dryness in the mouth and the dryness in the nose that can happen, the crusting, and that can be really frustrating as well. And so I recognize that too. And there are ways to kind of troubleshoot that. I mean, we can try and apply some water-based lubricants, and we'll talk about troubleshooting that a little bit. And then probably the most serious one that we're always concerned about when we prescribe it, the dangers, is that oxygen is like rocket fuel. Like, it can blow up, and it has before, and there's cases of this. It's happened in a hospital that I worked at where somebody lit a cigarette while they were wearing oxygen. And we see this, fairly frequently. This is probably the biggest nightmare of the doctors who approve the oxygen prescriptions in the province is these sort of house fires or apartment fires that start. So with all that, the job of the people who fund oxygen is really challenging because they have to weigh all of these health benefits with all of these potential risks and kind of determine where the balance is, what's the happy medium. And I will say the majority of Canadian provinces have their own oxygen guidelines. I used to work in Ontario. Ontario had some slight differences in terms of what they would provide, but they're all pretty similar. Most of them are based on data from COPD patients, and everything I told you about scarring in the interstitium, that's not how it works in COPD. Just for the sake of time, I can't go over both of them. But in COPD, folks tend to live at a little bit of a lower oxygen level more chronically, and they don't drop so severely when they exercise, unlike in interstitial lung disease. So in BC, there's two main oxygen providers. We used to have Vital Air being the sort of main one that was the go-between in our health authority in Vancouver Coastal, but now that seems to be switching to MedPro now. We think of them as roughly similar. There are some other oxygen providers out there, and usually these are the ones, though, that are contracted out by the province, and they have sort of their pick of who they've generated a contract with. There's some other ways you can get oxygen, too, if you don't go through the province. Your private insurance may fund it. You may have some degree of funding for a portable oxygen concentrator. Oxygen may also be funded by certain federal programs if you apply. And companies outside of those companies that I listed are also available if you apply privately, if you have some insurance as well. So how do we qualify? So the qualification is really based on some pretty narrow indications. So first of all, at rest, which is honestly not the majority of folks that I see, but if your oxygen is less than 88%, and we'll talk about how to measure it on one of these pulse oximeters, but if it's less than 88% continuously for 6 minutes, you'll qualify. But again, not many of my patients with interstitial lung disease will qualify on that basis. You can also do a poke, so sometimes your doctor may recommend doing a poke of the arterial blood. That's different than the blood that comes from the vein because that's before your artery has offloaded all that oxygen onto the muscle, so it really represents how much oxygen is coming in through the lungs. And there's certain thresholds that qualify you based on that test. A walk test is probably the most common way that we try to get folks qualified with interstitial lung disease. So many of you have probably already done a 6-minute walk test or some type of walking oximetry. We essentially have you walk back and forth, back and forth, back and forth down a hallway. We measure your oxygen level, and somebody follows you along to see what your oxygen does. If you fall below 80%, you qualify. If your oxygen does not fall below 80%, but it falls below 88% for over a minute, and then they try you on oxygen, you have to show an improvement. So you can't just say, yeah, your oxygen fell below 88% for a minute. You actually have to show that that treatment resulted in an improvement in your walk distance, which sometimes is really hard to do because maybe you haven't been exercising very much because of your lung disease. Maybe you're a little bit slower. And so even walking that extra 25% or extra 30 meters may be a lot because you may have actually given it your all that first time and now you're wiped. So that's always a challenging criteria, especially for folks with interstitial lung disease. And then the other way is overnight oximetry. So if your oxygen levels drop low at night, you may qualify that way. And then from my end of things, once you qualify, I do some paperwork, I send this into the government. Sometimes even if you don't qualify, I'll plead with them and say, this is why I think this person needs oxygen, please give them oxygen. And then we get a letter back as to whether or not they approve you. And through the home oxygen program, the suppliers will come into your home, they'll arrange to set up your equipment, and then the home oxygen program respiratory therapist will come to your home for an assessment several weeks later and make sure that everything's sort of getting along just fine. And reassessments may occur between 6 to 12 months by the home oxygen program RT. It depends on the specific health authority. I think Fraser Health comes a little more often than Vancouver Coastal, but somewhere in that time frame. We can sometimes ask them to come sooner if we really want them to come sooner to reassess things. Say, for example, if oxygen needs are increasing, if disease is getting worse more quickly, we can usually specially request that. So, as I've mentioned before, oxygen is prescribed in flow rates. So when we say numbers, your doctor may ask you your number. We're kind of concerned about two things. One is the number on that pulse oximeter on your finger in percentage, and then also the number that you have the dial turned to either on your oxygen tank or on your portable concentrator, and that's what's in liters per minute. And it can be either continuous flow, meaning it's always giving it all the time, or it may be pulse dose. So you kind of take a breath in, and when it sort of senses that negative sort of sucking in pressure in your nose, it then shoots out some oxygen that way. And so that works really well if you're somebody who has enough flow, like you can take a deep enough breath in. But I hear from people a lot that, well, I can't really take a strong breath in, and they may get the oxygen delivered sometimes when they're taking a breath and sometimes when they're not, and that can be challenging. So continuous flow is usually the more sure bet. Like everybody will get enough oxygen with continuous flow, but for some people, pulse dose is enough. So cylinders are really common. They're commonly prescribed by or given out by the home oxygen programs and the suppliers. They're cheaper in the initial run, but they're actually more costly if you think about them long term, just because the upfront cost of purchasing an actual machine, a concentrator machine, can be quite expensive. You usually put them on a trolley to bring them around, and these are just pressurized oxygen delivered by tubing. But they can be heavy, they can be hard to cart around, they're very visible. A stationary oxygen concentrator collects oxygen from the surrounding air, concentrates it, and then delivers it to you. These are really good for at home. They're like these big machines, they look like air purifiers or some type of air filter. And they're good if you're, just hanging around at the house or you're walking from maybe one room to another or your couch to a different chair. Portable oxygen concentrators essentially do the same thing. They concentrate oxygen from the air, but they're small enough that you can bring them around places. And usually they come in a nice little pack, so you can either put that on a side satchel, you can put it in a walker, on a cart, you can put it in a backpack. And the challenge with this, though, is that the upfront cost is pretty high. They can be anywhere between $3,000 and $5,000. Ways to carry your oxygen with you. So there's a lot of different ways around this, and I saw some backpacks around, I saw some side bags around, and these are really, really helpful to try to make life manageable with oxygen. And it also conceals it a little bit too, so you can so you don't always need to have it. You can sort of tuck that oxygen tubing in if you don't really need it, and just sort of carry it like a backpack. You can also get little straps for these D cylinders that go onto a walker as well. So there's different ways to carry it and lots of different products available. And your oxygen providers can usually help you sort that out. In terms of oxygen safety, so there's a lot of safe practices that need to be adhered to. If you're smoking, if you're still smoking, it's not that you can't get oxygen. We really, really try to get you to quit, but it is an addiction. If you can't quit, then usually the home oxygen company will contract with people and say, well, you're not allowed to smoke around your oxygen. I will be this far away from my oxygen. They actually get you to sign a contract and a waiver. The other safe practice is, of course, keep oxygen away from fire sources. So make sure that you're not near an open flame with oxygen. Check the tubing regularly to make sure that you're not leaking oxygen everywhere and sort of spilling oxygen out. Using a water-based nasal lubricant, so some folks, especially with that nasal crusting that can happen or that nasal dryness, want something that can help moisturize the nasal passages. We tell people not to use things like petroleum-based jelly just because they are flammable. So things like Saccharus nasal gel is a water-based gel, or any kind of water-based gel is a very reasonable option. And then always make sure you turn off your oxygen if you're not using it. So I'm going to go through a couple of frequently asked questions or things that I get asked quite often about oxygen. The first is, how do I monitor my oxygen levels? And I feel like I have this conversation a lot with folks in clinic, but I want you to all leave knowing how to monitor your oxygen if you don't already know. So you can pick up a pulse oximeter at any medical supply store or pharmacy. Usually we tell people to avoid just anyone on Amazon. Not that Amazon is bad, but you know that it's probably from a reputable source if you get it from, say, like Shoppers Home Health or London Drugs, or from a medical supply company. And get to know your normal level at rest. So start tracking what your level at rest is. And usually 95 to 100% is within normal range. And that's both at rest and exercise. You're in the green zone at that range. And you want to keep oxygen levels definitely above 90% at rest. With exercise, similar to what Dr. Schaefer was talking about, we try to keep oxygen levels greater than 88%. I'm okay if you continue exercising again for those few minutes between 88 and 92, or sort of the mid-80s range. Like, there's no hard and fast rule. This doesn't come from any particular rule that if you go to 81 or for a minute, or if you go to 85 for a couple of minutes, it's going to be problematic for you. But we just say as a general rule of thumb, if the oxygen levels are less than 82%, then we suggest that you stop, rest, wait until they come back up a little bit higher. The other question I often get asked is, do I need oxygen on my upcoming flight? So why do we need oxygen when we fly? So typically, most commercial airlines fly at 40,000 feet. As you heard me say before, there's 21% oxygen in the air. There's still 21% oxygen at 40,000 feet. But the pressure is really low. Anytime you're at altitude, all of those gas particles, even if there's 21% of them, are further apart. So you're actually breathing in less oxygen up there. And at 40,000 feet, for anybody, regardless of whether you have lung disease, that's going to be a problem. You're not going to be able to breathe. So how do we manage this? We pressurize the cabin. Pressurize it to 8,000 feet. So they pump in enough pressure, and probably for cost reasons and maybe airplane maintenance reasons, they don't pressurize it to sea level, but it's like you're on a mountain at 8,000 feet. So you can get an altitude sickness from being on a flight. If it's a long-haul flight and you have lung disease, it's kind of a similar type of idea. That's why if they say that if you lose cabin pressure, they give you oxygen. It's not that there's not oxygen in there, it's just you need that pressure to breathe in enough oxygen. But for most people with lung disease, it really depends, because it depends on the severity of your lung disease. When you're moving about the cabin, your oxygen levels may drop even further, similar to what we saw at the beginning. When you exercise, that blood moves faster through. So you may be okay at rest. You may actually need it if you're moving about the cabin. But definitely ask your doctor about your specific case and if you're safe to travel. If you're already on oxygen, a flow of 2 liters per minute additional to what you're taking should be enough. If you don't usually need oxygen, sometimes your doctor will send you for a high altitude simulation test where they have you breathe in a mixture that contains only 15% oxygen, and then they see, does your oxygen level drop? And if it does drop, then we suggest that you take oxygen in flight. The hard part, that's not covered by the government. So that's something you have to pay out of pocket for, but we can help you arrange through the airlines or help you rent a machine through one of the oxygen providers. Is oxygen a medication? I say yes, so it's something that we have to prescribe. It's used as a medical treatment, so it's considered a medication, and I consider it in medication lists. Is too much oxygen harmful? There are some settings where too much oxygen can cause damage, usually in the much, much higher doses of oxygen than we're using in folks with interstitial lung disease. And if you're an inpatient and we're giving you high flow oxygen for a long period of time and you don't need it, well, we try to turn that down. But even in those cases, the benefits usually outweigh the harms. As I said, not a concern with the amount of oxygen we're talking about. Can I get addicted to oxygen? No. Supplemental oxygen will not lead to you needing more oxygen or your body being less able to extract the oxygen, but I know that's a concern. If you start to notice more oxygen's needed, that has more to do with the fact that that scarring that we saw between the alveolus and that blood vessel is just getting thicker and denser with time as disease progresses. And thank you for the time, and I'll be around to answer questions during the panel discussion.